If we could eradicate inflammation, we can't today. We don't have the right drugs to do it today. The drugs that are used today to powerfully suppress inflammation do it by powerfully causing immunosuppression. When you immunosuppress a person, you lower their immune system's ability to fight off infection, to fight off cancer, and to participate in normal wound healing. And so what happens is today we're trading off the benefits of decreasing inflammation, have less pain and less swelling and less suffering. We're trading that off with adding now new risks of immunosuppression, which include cancer and sepsis and tuberculosis and fungal infections and impaired wound healing. That's where we are today. The real question is, if reversing inflammation safely reversed the mortality of those conditions, yeah, it would change the game. And it may be that one mechanism that the nervous system uses to control inflammation is by sending signals up and down the inflammatory reflex in the vagus nerve. But as scientists and as investigators, we can ask questions about what are other nerves doing to other organs, controlling inflammation in other parts of the body. I wrote The Great Nerve specifically to provide a platform of basic information about the vagus nerve and its implications for inflammation, because I wanted people to understand.
Okay, Dr. Tracey, welcome to the show. To get started, can you tell us why you've spent the past 3 decades of your working life studying the vagus nerve?
When I was training to be a neurosurgeon some years ago, 40 years ago now, I took care of a patient, a little girl who was severely scalded in a kitchen accident in her home. And when we cared for her in the burn unit at the New York hospital, we watched as she went in and out of sepsis and in and out of conditions characterized by inflammation that spread throughout her body. And she battled through this for a month and then inexplicably one day died in my arms. I had no way to explain what had happened to her. We did not find any infection. We did not find any evidence of, other than her burn injury, no reason to explain why she had suddenly gone into shock and died. I decided at that point in 1985 to work on understanding the problem of inflammation causing damage to healthy tissues, to healthy physiology. And that's a path that set me on the one I'm on. I'm still on today after 40 years, trying to understand how inflammation works. And in the case of the vagus nerve, how the brain uses the vagus nerve to control inflammation. That happened in the 90s. The 1990s, the late 1990s. We were looking at a molecule we had invented to stop inflammation. And this molecule we called 1493, and it was a very good anti-inflammatory molecule. We did many, many studies on this. And one of the studies was to put 1493 into the brains of animals to use it to suppress inflammation in the brains of mice and rats with a stroke. And it did that, and we were very pleased. What we didn't expect in those experiments is that the presence of the drug in the brain of the animals stopped inflammation in the body of the animals. This was a huge surprise. It was very baffling. And for many weeks and months, we thought about how could this be? How could a very small amount of a molecule in the brain of a mouse cause the body of the mouse to stop making too much inflammation? And the answer turned out to be that the drug in the brain was activating signals in the mouse's vagus nerve. And these signals were traveling from the brain to the spleen to suppress today, what we call today, cytokine storm. And by the vagus nerve signals stopping cytokine storm, this was a way for the brain to send signals through the vagus nerve to inhibit or slow down inflammation. So what we had discovered, quite simply, is a reflex circuit traveling in the vagus nerve that acts like the brakes on your car to slow down inflammation.
That's incredible. Can you maybe give us, just so we're all clear on what we mean by the vagus nerve, what actually is the vagus nerve? And I'm aware there's two of these, isn't that right? And each has about 100,000 fibers each, roughly.
Absolutely right. So for social media fans, the vagus nerve is the source of billions of web impressions and social media posts. So a lot of people are talking about the vagus nerve right now, and that's great. It's one of the reasons I wrote a book about it recently. You're absolutely right. We say the vagus nerve, but we actually have two of them, one on each side of the body. It starts at about in the brain at about the level of your ears and travels down each side of your neck, one on each side, across each side of your chest, down into your abdomen. And along the way, it sends branches from the vagus nerve that travel to all the organs that you don't think about or are not conscious of all day long. Your heart, your lungs, your liver, your spleen, your pancreas, and on and on. And you're also absolutely right. We don't have one vagus nerve, we have two. And inside of each of those vagus nerves is 100,000 fibers. So we all really have 200,000 vagus nerve fibers, or individual vagus nerves. Now, what's interesting about this, and very important, is that each of those fibers has a specific place that it originates and in the brain or the body, and a specific place that it ends in the body or the brain. And this anatomic organization of the fibers is embedded with, intertwined with the function of those fibers. So the path of the fibers and the job they do evolved over millions and millions of years of evolution. And so it's really important to talk about the vagus nerve in the plural, because these hundreds of thousands of fibers are carrying millions of signals, each of which has a specific function for a specific organ or a specific effect and a specific response. And so it's not a solid copper wire, and understanding how much information and how much specificity is embedded in these vagus nerves is key to understanding not only how it works, but it's also the key to understanding how we can harness those signals to help patients with serious conditions, ranging from inflammation to depression to anxiety to other things.
And obviously I'm quite unfamiliar with the field, but are you guys any closer to sort of being able to differentiate and target, say, individual fibers within that 200,000 that are available? Can you do that?
Yeah, you can. Well, you definitely can do it in mice. So in mice, you can genetically manipulate the systems so that you can target the activity of individual specific fibers, literally one at a time. And you can do this with chemicals called pharmacophores, or you can do it with laser light called optogenetics. And so in mice, we're gaining very important information about how these things work, fiber by fiber, or groups of fibers by groups of fibers. In animals, it's also possible. In pigs, for instance, my colleague here, Stavros Zanos, at the Feinstein Institute in New York, has been using focused ultrasound to steer the stimulation signals in the focused ultrasound to target just small numbers of fibers in the pig vagus nerve rather than the whole fiber. He can stimulate subsets. And in humans, in clinical trials that were led by the company I co-founded, Set Point Medical, in humans, it's possible to stimulate small numbers of fibers by putting in a small amount of current. So you can put the electrode, if you will, the stimulating electrode directly on the vagus nerve in humans. But within those 100,000 fibers, the individual fibers have different thresholds for being activated by incoming electric current. So the low threshold fibers would be turned on by small amounts of current, whereas the more resistant or higher threshold fibers would require a lot more current. As it turns out, in patients with rheumatoid arthritis, when we put in a relatively small amount of current, 400, 300, 400 microamps, which is a very small amount of electricity administered in pulses, that is sufficient to activate the brakes, the fibers that stop inflammation. But it's not sufficient to activate all the other fibers that have other functions controlling, for instance, heart rate. So we're getting specificity with an electrode because we're putting in the right amount of current. So there's a lot of work going on. It's a little bit of a holy grail in biomedical engineering to convert the fiber-specific specificity that we can do in mice into humans. We don't need to do it today because what we're doing now works. The FDA has approved vagus nerve stimulation to treat rheumatoid arthritis in the United States in patients who are refractory to other therapies. And so that's all good. But as a research project and an engineering project, there's a lot of interest in that.
Okay, that's fascinating. Am I right in saying that of those 200,000 fibers, 80% of those are traveling from the organs up towards the brain, and only 20% are traveling from the brain to the organs? And if that's the case, if that's the case, why is that so significant, do you think?
It is the case, and it's significant for many reasons. Some philosophical, some medically relevant, and some important just for understanding how biology actually works. So let's start with how biology actually works. We tend to think, most of us tend to think top down. There's a brain. Human beings are really smart, at least most of them that I know, and they can organize their thoughts and ideas, and they can express their needs and wants, and they can express those ideas, and they drive the output of the brain drives hitting the golf ball or playing the piano or walking out to get a cup of coffee. But that's not how biology works. Biology works actually the other way. Something changes in the environment of your body, your pancreas, your blood pressure, the temperature of your skin. Something changes, and that initiates signals that travel from your body up into your brain in the sensory nervous system. Those signals are the input to your brain, which is sitting there watching everything going on and processing these signals as reflex inputs. The inputs are translated into outputs. And if your finger lands on a hot stove, the output of the temperature input, that there's heat on your finger, causes you to pull your arm away before you even think about it. The same thing is happening for when your heart rate deviates from the set point, so it starts to go too fast or too slow. The input to your brain sends signals back down your vagus nerve to slow down your heart. When your breathing changes, the input from your lungs to your brain travel up your vagus nerve to tell your brainstem that you've taken a big breath or you haven't taken a breath in a little while. All of these inputs drive the outputs. And so it really does raise important philosophical and psychological questions. I mean, these experiments have been done many different ways. You can, for instance, you can put an athlete, say a baseball player, into a like an MRI machine that's monitoring the activity of the brain of the athlete, and you can put on goggles or a headset. So now the batter's in the athlete's in the batter's box waiting for the pitcher to throw a fastball, and the task is to report when the batter decides to swing at the fastball. And this is just one example of these kinds of experiments, but the batter muscles, the muscles in the batter's arms and legs start to swing before the batter decides that she's going to swing the bat. And so, yeah, you're 300 or 400 milliseconds late to every party. And that raises questions about free will that we're not going to get into today because I don't know enough about it. But I do know enough about reflexes to know that much of healthy physiology, homeostasis it's called, a balanced relationship between all of your organs functioning in a healthy way, those balances, much of them are controlled short-term by reflexes that are operating minute to minute. And all of those reflexes begin with inputs. They begin in the body, not the brain.
Wow. Can you tell us about the story of Kelly Owens, Kevin?
I met Kelly Owens after she had sent me an email one day. The subject line was something on the order of, "Thank you for saving my life." And what I found out from reading that email, which I think was around 2017, was that Kelly had, as a teenager, been diagnosed with Crohn's disease, inflammatory bowel disease, which is a painful gastrointestinal illness that had caused her to be treated in the greater New York area, New York and New Jersey, traveled to the Mayo Clinic, and ultimately to Hawaii, all for over a period of many, many years, seeking therapy. Amongst her many symptoms from her Crohn's disease, Kelly developed a severe form of arthritis, crippling arthritis, and she was intermittently, when she wasn't hospitalized, she was in and out of wheelchairs and struggled to walk on some weeks and months, to the point that her father actually gave her a cane. So Kelly was told by her doctors there were no more therapeutic options. She had tried biologics, the injectable immunosuppressive drugs that block cytokines. She had tried powerful steroid medications and other powerful anti-inflammatory drugs. And her doctors told her that she should get used to a life of being on drugs and get used to a life of being in pain. She saw me on Huffington Post Live talking about SetPoint, the company I mentioned before that I started with Shaw Warren, my co-founder, in order to test the idea of whether we could use vagus nerve stimulation to treat patients with severe inflammatory conditions like Kelly. Kelly learned that there was a trial going on in Amsterdam. She and her husband, Sean, sold all their worldly belongings and moved to Holland, talked her way into the trial. And within a couple weeks of the clinical trial, she was significantly better. And within a month or 6 weeks, still living in Amsterdam, she found she was going for a doctor's visit as part of the trial to get checked on her progress. And she saw that she was running late and there was an elevated train, and she ran up the stairs to catch the train. And standing at the platform looking back, she sees her husband, Sean, standing at the bottom of the steps, like, "What the heck are you doing? Let's go." And he's standing there with tears of joy streaming down his cheeks because he had not seen Kelly run in years, never mind run up a flight of stairs within 6 weeks after having that vagus nerve stimulator implanted. So that was 8 years ago. And I spoke to Kelly about a month or so ago, and she's doing great. She takes no medications. She has no symptoms of her Crohn's disease or her arthritis. And I can turn the camera if it won't, distract too much. But what you see there was her gift to me. It's her cane sitting in the corner of my office. She doesn't need it anymore. And I didn't unwrap it completely. I left the bow on it. But I got to know Kelly very well because we hired her here at the Feinstein Institute in New York. And for many years, she worked with us collecting all of the emails that we get and all of the phone calls from patients offering to help by participating in clinical trials or other things. And Kelly helped us build that database. She retired from working with us and is now restoring guitars and she's feeling great. And so it's you meet a patient like Kelly and you feel forever grateful for what we get to do. I love doing research. I love working with brilliant colleagues. I love running the laboratory at the Feinstein with my colleague Sangeeta Sivan. She and I co-head the laboratory, and I love what I do. I picked this career, and I'm working through these career steps. Kelly's the hero. She didn't choose to have her illness, and she did choose to participate in the clinical trial. And the fact that she's better, I mean, like I said, if I'm having a bad day, I just turn around and look at the cane and remind myself why we're all doing what we do. We're very lucky.
What was it like whenever you got that news and it sunk in what had actually happened, like what you'd done for this person? You'd given them back everything. What was that like? Remember that happened?
It was a high point of my professional life, without doubt. And because all I ever wanted to do in my professional life was pursue scientific questions in the hopes of producing new knowledge to cure someone's disease. And along the way, I think some people think that you do science because you're good at math and you memorize a bunch of science in high school and college. That's not what it is at all anymore. Doing science today requires sort of relearning everything every year because things are happening so fast. And it requires learning new ways of doing science every year because the technology is changing so fast. And that means it requires constantly building new teams of people. I mean, if you work on something in the laboratory, you need to assemble a team of students and postdocs and professor colleagues to collaborate on all these rapidly changing things. But once you have an idea that what you found may actually be useful for patients, you need to build new teams of people to do clinical trials. You need to build new teams of people to start companies. You need to build new teams of people to get investors in those companies to pay for the clinical trials. And once the early clinical trials are successful, then the company has to build new teams of people to take it through the regulatory steps. And once the regulators say it's approved, you need even more teams of people to deal with the financial realities of insurance reimbursement, hospital deployment, surgical utilization. So everything's different every year. It's different questions, it's different projects, it's different people. And what's so interesting to me about it is 25 years flies by when you're doing so many interesting things with so many interesting people. And then you get to meet Kelly and it's like, well, let's do it again.
For sure, for sure. Okay, so we've spoke a lot about inflammation. What exactly is inflammation, Kevin? How would you define that?
Inflammation was originally defined by the early Greek and Roman physicians as the presence of redness, pain, swelling, and heat that occurs at the site of an injury or infection. We've all seen it. If you sprain your ankle or broken your wrist or had an infected mosquito bite, you see the redness, the heat, the pain, and the swelling. That's inflammation. And that definition is still a widely used definition of inflammation today. What's happened in the last 2,000 years, primarily in the last 40 or 50 years, is we've gotten a very good handle on the molecules that are involved in those cardinal signs of inflammation. And those molecules have names like TNF and IL-1 and IL-6. Those are the cytokines. They have names like prostaglandins and eicosanoids. Those are the molecules that are blocked by anti-inflammatory drugs like ibuprofen and aspirin. The cytokines, of course, are blocked by drugs like the biologics, like monoclonal antibodies and other things. So we've changed our definition of inflammation to focusing now on the molecules that cause it, because we can block those molecules with drugs. So that's all good, but it's actually created some confusion and some imprecision, if you will, because when we talk about a condition, say Alzheimer's disease, we talk about the inflammation in the brain, or the neuroinflammation, it's sometimes called, and that this inflammation may be contributing to the Alzheimer's disease itself. And the disconnect is what we're actually talking about are the activities of white blood cells in the brain, or the activities or the measurements of some of these molecules like the cytokines or the eicosanoids or prostaglandins in the brain. But if you look in the brain of an Alzheimer's patient, you don't see swelling. You don't see, obviously, redness, increased blood flow. There's no pain. And so is that really inflammation, or do we need it, or is our language failing us at this point? Because we're focusing so much on the molecular mediators of inflammation in the hopes of making drugs. I mean, it's for good reasons, and some of the drugs we made are very, very good. But I think I wrote about this in my book, The Great Nerve. I think we come up short in our nomenclature now, and we may, and some people have tried to do this. They talk about meta-inflammation, or they talk about tissue-specific inflammation. Another example would be adipose tissue. If you look in the fat tissue of obese patients or obese subjects, again, you'll see elevated production of cytokines, which can cause insulin resistance. And so but you don't see a lot of white blood cells. You don't have heat. You don't have swelling. You don't have pain. But people call that, because there's increased cytokines, people call that the inflammation of the adipose tissue. So it's a really important point. In science, it's very important to be specific. Sometimes you have to be descriptive, but in order to be mechanism driven, we have to be very specific and precise. So we may need to stop and reconsider our definitions a little bit. But suffice it to say, cytokines are very important mediators of inflammation, and we have drugs that target cytokines that can control inflammation. And this has generated a lot of interest in trying to use those drugs and related molecules to treat other conditions like Alzheimer's or like obesity. There's a lot of interest in treating those conditions with drugs to modulate the inflammation and to see if that has a benefit. We're not there yet. There's a lot of research going on, but there's certainly a lot of interest.
And, just in terms of impact and potential here, I've heard you speak about, there's parallels potentially between inflammation and infection, in the sense that before we had a scientific understanding of what infection actually was and how to sort of prevent it and mitigate it, it led to tens of millions, hundreds of millions of deaths worldwide. And the same with inflammation now. Like, it's potentially the root cause of millions and millions of deaths. And if we're able to get a handle on it scientifically and develop proper treatments for it, it could quite literally save so many lives.
So that is a testable hypothesis that you just generated, which I find extremely interesting. So to break it down to numbers, on the planet Earth every year, according to the WHO, approximately 60 million people die annually. Approximately 40 million of those people die of conditions like heart disease, stroke, Alzheimer's disease, diabetes, well, Alzheimer's and other neurodegenerative conditions like Parkinson's, diabetes, metabolic syndrome, cancer, and a few other conditions. These conditions all have in common the fact that inflammation, with the caveats that we just talked about, or we might need new definitions of inflammation, but inflammation in some form contributes directly either to the cause of some of those conditions or to the worsening or acceleration of those conditions. And so the question you ask is a really important one. If we could eradicate inflammation, because we can't today, we don't have the right drugs to do it today. The drugs that that are used today to powerfully suppress inflammation do it by powerfully causing immunosuppression. And so when you immunosuppress a subject, a person, a patient, you lower their immune system's ability to fight off infection, to fight off cancer, and to participate in normal wound healing. And so what happens is today we're trading off with our drugs that powerfully suppress inflammation. We're trading off the benefits of decreasing inflammation to have less pain and less swelling and less suffering. We're trading that off with adding now new risks of immunosuppression, which include cancer and sepsis and tuberculosis and fungal infections and impaired wound healing. So that's where we are. That's where we are today. The real question is, if we could safely control, reduce inflammation without causing immunosuppression, what would happen to those patients whose cancer today is being caused by inflammation? What would happen to those patients whose heart disease is progressing or was caused by their cardiovascular, their coronary artery disease, which is caused by and made worse by inflammation? What if that stopped? What if we could stop the inflammation that was contributing to the insulin resistance in diabetes and type 2 diabetes and metabolic syndrome? If you could, if reversing inflammation safely reverse the mortality of those conditions, it would change the game. And that, I think, based on the numbers, 2/3, 40 million out of 60 million, that should be sort of one of the calls to action for further study and further research, because it may be within reach. It may be that one mechanism that the nervous system uses to control inflammation is by sending signals up and down the inflammatory reflex in the vagus nerve. But as scientists and as investigators, we can ask questions about what are other nerves doing to other organs, controlling inflammation in other parts of the body, and how can we study the control of those signals by neural networks in the brain itself that could be modulated with either devices, brain implants, deep brain stimulators, or potentially using drugs. So these are all important research questions, and sometimes the hardest part of a research project is picking the right question.
I'd love to know, like, if you could see a breakdown of the figures of the money being devoted to different sort of areas of research, particularly in the medical field, how much of it would be allocated towards this particular area, because the potential just seems enormous. But I wonder, is it currently underfunded? More than likely, I would say yes.
I don't know. Those numbers are out there. You're probably right. They're probably the, the field would benefit probably from more research support to these questions. I would say the good news is that neuroimmunology, this field looking at this intersection of the brain and the immune system, of the nervous system and immune response and the inflammation system, this is one of the hottest areas in all of science today. Um, if I talk to 100 young people, 60 of them want to go into this field. They want to use the powerful tools in molecular biology, genetics, neuroscience, imaging, brain imaging, and the powerful tools in immunology, looking at individual immune cell activities and immune cell functions, and see how those come together. Because when you find out place they come together, you can make a drug or a device to modulate that, and that's exciting. That's exciting on the science side, and it's exciting on the development or cure side.
And am I right in saying there's been a study done with your treatment on depression, and it was 50% effective? And the idea here is that in the cases where it's actually working, maybe the thing that's causing the depression is the inflammation. And if you're targeting the inflammation, you're also helping to alleviate the depression.
You were right about everything except the pronoun my. There's no my in this, and let me explain. So the vagus nerve stimulation as a FDA-approved therapy for depression in the US and in Europe goes back like 35, 40 years. So at the time that my colleagues and I made the serendipitous discovery that putting a molecule in the brain of a mouse activated the vagus nerve to stop inflammation. At the time we made that discovery, the FDA had already approved the use of vagus nerve stimulation to treat epilepsy, and soon after that, depression. So vagus nerve stimulation for epilepsy and depression has been around for many, many decades. And it didn't catch on. As I think it should have. We'll talk about that now, but I would bet you most of your listeners didn't know that vagus nerve stimulation is an FDA-approved treatment for treatment-resistant depression for many, many decades. And I'll bet you many of them would be surprised to learn that hundreds of thousands, perhaps 1 million patients worldwide have received vagus nerve stimulation surgery for a device to treat either epilepsy or depression. It's just not widely known, and it hasn't been widely prescribed. And so now the question is, why did it get approved? How does it work? And why isn't it more widely used? Well, those three questions are all related. So we don't know the mechanisms of depression. It's not serotonin. The fact that SSRIs are widely used and make many people feel better, that's great. But there's no evidence that serotonin itself is necessary and sufficient in a cause and effect way for the condition of depression. So we don't know what the underlying basis of depression is, but we do know something else. Other patients who were treated with epilepsy, to have a vagus nerve stimulator implanted for their epilepsy, it worked. It was effective in controlling seizures in about half the patients. So after some period of time went by, this is back in the 1990s, the doctor said, well, you're unfortunately in the group where your epilepsy, your seizures are continuing, so why don't we remove the vagus nerve stimulator? It's not working. You don't need it. We're going to take it out. And many of the patients said, no, leave it in. And the doctor said, why? And they said, because I feel happier. I feel better. I have a better outlook on life. That clinical effect, that clinical observation is what led to clinical trials of putting vagus nerve stimulators into patients with treatment-resistant depression. Many of this early work and some of this continuing work was led by Dr. Charles Conway in St. Louis, Missouri, and it's a small world, and this comes into the small world department. But I trained in neurosurgery at the New York Hospital, Cornell Medical Center in New York City, and when I was an intern or a junior resident in neurosurgery, the chief resident was a guy named Bill Bell. And I knew Bill a little bit. We were friends. Didn't spend a lot of time together because he was the chief resident. I was just the intern. But it turns out that Bill, when he finished his training at the New York Hospital, he moved down to the southern United States, South Carolina, I believe, and he implanted the first vagus nerve stimulator in a human for the treatment of severe refractory epilepsy. And so Bill told me, as I was writing my book, he told me that the most dramatic cases he had were in patients with serious depression, who some of them might have been suicidal or unable to care for their family or participate in their job or in society. And the device would be turned on, and about half of them would have significant improvement or sometimes dramatic effects. So then why don't you know about this? Why doesn't everybody know about this? Because it only works half the time. And there's been a real resistance on behalf of payers in the United States, commercial payers, and there's been resistance on behalf of prescribing physicians. Oh, well, we don't want to subject my patient to a surgery, even though we know the surgery is safe and doesn't cause immunosuppression. And so it hasn't caught on, but I think it's because we don't know how it works. 50% to me is a very important number. It seems to work or not work. What I don't have the answer. In my book, I'm pleading with my colleagues to double down and study this more. One possibility is, however, I think a reasonable hypothesis, a testable hypothesis, is that some patients may have their depression being caused because they have inflammation somewhere in their body. And if I inject you with those molecules we talked about, like TNF, which causes inflammation, if I inject that into you right now, you will get depressed. You will get anorexia. You'll get fatigue. You'll get muscle aches and pains. You'll lose your interest in your friends and your job, and you'll just want to curl up in bed and turn the lights off. So we know inflammation can produce behavioral conditions that look just like depression. And we know that vagus nerve stimulation can turn off inflammation. So what if somewhere in the body of these patients, there's an imbalance in their inflammation that's being restored by vagus nerve stimulation, and that's why they feel better? It's possible. I don't know this. It needs to be studied. But just in the last couple of months, Dr. Conway published one of his most recent follow-up studies, and he showed that in the patients who do have a response this is treatment-resistant depression patients who do have benefit from the vagus nerve stimulation therapy, that 80% of them have a durable benefit for 1 to 2 years out. So these are significant things. And given the fact that depression and anxiety is sort of a growing worldwide problem, I think we should be doubling down and studying these mechanisms more.
Yeah, that seems a fairly reasonable hypothesis to me, anyway. This has also been used to treat. It's been effective for PTSD as well. And you give a quote which I find really interesting. But thinking about it, it's from Plato. Actually, it's, you can't heal the body unless you also heal the soul. And I'm just wondering about your thoughts on the mind-body connection, given all of the work that you've done in this area.
Well, I'm not a psychologist or a philosopher, so that's an important disclaimer. Um, but I am a neurosurgeon, and I have spent a lot of time in my life thinking about how brain circuits interact with each other and with the body. And we've learned quite a bit from studying subjects, people who've had vagus nerve stimulators implanted, and then those same subjects being studied in fMRI machines or other sophisticated brain imaging studies, PET, far field evoked responses. And what we've learned is that when the vagus nerve stimulator is turned on, signals traveling from the body up the vagus nerve into the brainstem activate brain centers that have been implicated in attention and arousal and emotion and memory and learning. And we've learned from clinical studies in patients who were subjected to some sort of learning program or test before and after the vagus nerve stimulator is turned on, that vagus nerve stimulation can enhance these cognitive abilities. And from beautiful work from Texas by Michael Renneker and his colleagues, we've learned that the timing of the vagus nerve inputs to drive these responses in the brain, the timing of the input is critical because a unifying sort of mechanism in the brain, which we don't completely understand, but it explains a lot, is increasing neuroplasticity. Neuroplasticity is the ability to form new connections and facilitate new learning or repair damaged connections to restore their function. And on this basis, the enhancement of neuroplasticity with an implanted vagus nerve stimulator has been, in the United States, FDA approved for enhancing the rehabilitation therapy in patients with a stroke affecting their arms. So if you've had a stroke and can't use your arm, what patients with that condition say is, I want to be able to feed myself, I want to be able to scratch my face, I want to be able to write a letter to my children. These functions can be restored in many of these patients by adding the vagus nerve stimulation therapy to the rehabilitation of the arm. And so these are dramatic effects. That same principle was applied to what you just referred to in the post-traumatic stress disorder study, which was done in a similar way. So the standard therapy for PTSD is an app, and it generates feedback. So you use the app on your phone, and it tells you to think a certain way or undergo a certain behavior, and it's a reasonably good psychological therapy for PTSD, but it's not great. It's not perfect. When Michael Renneker, I believe this was one of their Nature papers, when they added the vagus nerve stimulation therapy to the use of the app, and they paired the input on the vagus nerve, the stimulation itself of the vagus nerve, to the instructions being given by the app in a time-dependent way, the response, the PTSD response, the improvement response was nearly 100%, which is a dramatic, remarkable effect. And so I agree with you. It's an incredibly important finding. It will, I'm sure, now have to be replicated in a follow-up trial. But I think there's going to be a tremendous amount of interest and attention into the mechanisms, which we don't completely understand, of how vagus nerve stimulation enhances neuroplasticity in the brain.
To me, it's just shocking. What size are these electrodes roughly? Like, if you had to, give an analogy.
I think I have one I can show you. It's The ones that the devices that have been FDA approved for several decades for epilepsy and depression are about the size of a silver dollar or a little bigger. It sits under your clavicle, under your collarbone, and there's a wire, a lead that is passed under the skin up to the vagus nerve in the neck where it's connected. And so that's the historic. I call that the Gen 1 vagus nerve stimulators. Those are very much like cardiac pacemakers, and the battery has to be replaced every 10 years or so. What I call the Generation 2 devices are like this one. They're about the size of a multivitamin, and these sit right about the level of the Adam's apple under the skin. This device is fully self-contained. It has an ASIC, a computer chip. It has a lead. It has a battery. It has an antenna. All of this sits in a little silastic pod, which sits on the vagus nerve runs through the bottom of it, through that hole in the bottom. I don't know if you can see it. And then the surgeon puts a stitch through the top of it to hold it all in place. So this is the future. This battery will be labeled, I believe, for 10 years. But engineers I've spoken to told me they think it will last much, much longer than that. It's fully rechargeable through the skin. The patient puts a collar on, an induction collar, for a couple hours a week. And just like charging your iPhone, you put it down or your Android or any phone, you put it down on a pad and it charges. In this case, you put the pad around your neck to charge the battery in the device. So I call this Gen 2. This device to treat rheumatoid arthritis is actively delivering stimulation to the inflammatory reflex for 1 minute a day for 400 microamps, which is why engineers are confident the battery will last for a long, long, long time. And that 1 minute a day of therapy activates signals that travel down to the spleen. But what happens during that 1 minute is those signals are amplified at each step, from the vagus nerve to the ganglia, from the ganglia to the spleen. Inside the spleen, there's the release of neurotransmitters, which activate the release of another neurotransmitter. And this goes for hours after a 1 minute, like pushing a snowball down a hill. And those effects culminate in lowering inflammation, not to zero, which is what the biologics do, but lowering it from, say, 100% to 50%. So you're not getting immunosuppression, you're just taking away the toxicity. And that's what's happening now. And we're currently here, I'm in my office at the Feinstein Institute at Northwell in New York. And just down the hall from me, we opened the first bioelectronic medicine clinic to convene the neurosurgeons and the rheumatologists and the neurologists and the internal medicine physicians and the patients in a clinic, so we can share best practices and identify patients who would be ideal candidates for this type of vagus nerve stimulation therapy.
This is just insane. So this thing will sit just under the collarbone, and for one.
This one sits at the level of the Adam's apple.
At the Adam's apple, right? And
yep.
It only needs to run for about 1 minute a day, and then that has snowball effects for the rest of the day, and reduces inflammation by up to 50%.
That's exactly right. We in patients now. Again, the patients in the clinical trial, which is published in Nature Medicine a couple of weeks ago. I think it's the cover story. I'm not sure. But these patients, many of them had spent years on the most powerful immunosuppressive drugs available: methotrexate, steroids, anti-TNF, anti-IL-1, anti-IL-6. And despite these therapies, these patients still had persisting rheumatoid arthritis, pain in their joints, swelling, redness. or some of these patients couldn't tolerate taking the drugs. The side effects were too severe. And so these are the kinds of patients that got this implant. And in those patients, 80% of them had a benefit 1 year after the implant. I mean, that's remarkable. These are people who were having essentially no benefit from these expensive, dangerous drugs. And now with a sort of one and done operation, about an hour long, they're 80%, not 100%, nothing's 100%, sadly, but about 80% of them had significant benefit. And of the 80% with significant benefit, about half of them had benefit to the point where well, they'll tell you themselves that this has turned their life around.
This all makes me think, like whenever it comes to our health and our well-being, like one of the central things to focus on is inflammation, and trying to live in such a way that we're keeping our inflammation as low as possible in everyday life, and just figuring out what that involves in terms of exercise, what involves in terms of sleep, eating, and different practices for just keeping inflammation low as a central variable in living a long and healthy life. What are your thoughts on that?
I agree with you. I agree with the premise, and I agree with the goal, and I agree with the tactics that you listed. I think in my own life, I try to get enough sleep. I try to eat a healthy, balanced diet. I try to watch my weight. I try to exercise regularly. I try to stay engaged in obviously with my loved ones, friends, family. I try to find ways to give things back to society, and I try to find ways to minimize unnecessary stress and anxiety, whether it's meditation or cold showers or vigorous workouts. These are all things that tend to reduce inflammation. Some of those benefits, are they coming through these signals in the inflammatory reflex of the vagus nerve? Maybe. Can we, say that as a statement of fact that the vagus nerve explains all these health benefits? As a statement of fact, no. Is it a testable hypothesis? Yes. So the answer is interesting, and again, it's maybe. The problem isn't that there are billions of web impressions about the vagus nerve in social media posts and online. That's not the problem. The problem is when people are trying to sell you something, at which point I would say let the buyer beware. And the problem comes when people make bold claims about cause and effect, linking the vagus nerve to everything, which frankly are not supported by either rigorous clinical trials or by hard scientific evidence. And so people say, well, what's the harm in that? Well, the harm is that it undermines the studies that are supported by hard scientific evidence. And it cheapens them, frankly. So you have people now standing to benefit significantly from the implant of a vagus nerve stimulator to treat their refractory rheumatoid arthritis. And that requires, obviously informed patients, but it also requires informed physicians and informed hospitals and hospital networks and informed payers. And you don't get that right now from those billions of web impressions. That, frankly, Niall, that's why I wrote my book. I wrote The Great Nerve specifically to provide a platform of basic information about the vagus nerve and its implications for inflammation, because I wanted people to understand what some of these stories are, the patient stories and the research stories, but also to understand this is what we know because it's backed by years or decades of great scientific evidence. This is what we know to be true. This is what we know to be false. And these are the things that, while they may have some basis in scientific reasoning or historic reasoning that are interesting, that should be studied, we still just don't know enough.
Yeah. Well, I can't imagine how frustrating it would be for you, to have done these decades of very difficult clinical research, and then just to have people coming out in social media like trying to sell something and trying to make a quick buck off it. That must be hard to sort of see, because that would then diminish the credibility of the research that you guys are doing, which is not cool.
Well, I think the important point is it comes down to what does an individual patient want. So you will talk to patients, to friends, to families, to your listeners, and they'll say, "Well, I bought this thing, and it only cost me $500, 500 pounds, 500 quid, and I feel better when I use it, and my doctor said it's not going to hurt me." Well, fine. Not if you have $500 and it makes you feel better, great. I mean, no harm, no foul, right? That's different than the people selling these things, claiming they know either how it works or what it does, absent significant support from clinical trials and from or from scientific mechanistic studies. And then some would say, "Oh, it's a conspiracy. He just doesn't. When these guys, they don't want people to know about this stuff." Well, and that's why my doctor doesn't prescribe it for me. Well, no, it's not that simple. Your doctor is held accountable for prescribing things that she thinks are in your best interest, as supported by the best clinical trials, and as recommended by medical societies who spent years and or more studying best practices with first do no harm as the endpoint. Do no physical harm, do no mental harm, do no financial harm. It does, Hippocrates didn't specify, right? He said no harm, period, full stop. So those constraints mean that don't mean that the system is rigged against the patient. The system is rigged to minimize the cases of any harm or suffering. And the problem with many of these devices, and I've purchased many of them to play with them, and I've studied some of them, and I've done the literature searches on whichever ones I could find in the timing of my book, which came out a few months ago. It's amazing what little clinical testing, at least in the public domain, most of these devices have been subjected to. Even some of the FDA devices have been tested in clinical trials in like 20 patients or 40 patients. I mean, that's nothing, to extrapolate the data from 20 or 40 patients to a treatment recommendation for thousands or millions of patients. That's why insurance companies don't pay for most of these things, for most of these devices that do this, that, or the other thing according to the advertising on Facebook and Instagram and TikTok. So I don't have a problem with people trying things if their doctor says it's safe, safety first. And I don't have a problem with people selling things trying to make money. That's how the world works. I get it. But let's not claim all these scientific mechanisms and understanding unless the studies have been properly done, because that's a form of disinformation, frankly. And that really does slow progress. And that really, at the end of the day, if you slow progress, you do hurt everybody.
For sure, for sure. Okay, well, Kevin, we're out of time. I just want to say thank you so much for your time today. I've really enjoyed this. I've learned a lot. Where can people learn more about you, your work, and get your book, The Great Nerve?
This is a setup, Niall. The book's available everywhere books are sold. Thank you for that softball. Most of our scientific work is available either at the website of the Feinstein Institutes for Medical Research, or it's available on Google Scholar or PubMed. The book is written for the general public, as I said before, for patients, for the patient's doctors, and for relatives and family members of patients, or for anyone who wants to learn about the vagus nerve. I do talk about the science for some of these wellness strategies that are widely promoted on social media. I talk about cold plunges, and I talk about exercise, and I talk about breathing and relaxation, and I talk about these things in the way that they have been studied carefully with endpoints that make sense in the context of inflammation and physiology. And there's some interesting studies that have been done that support some of these practices, which is why I do them, frankly. The issue is, and I discussed this in the book, we need better, bigger, larger studies of these very specific modalities before you're going to see them broadly embraced by the average physician or the average practitioner. And I plead for that in the book too. I think more studies is always better.
For sure. Okay. Thank you, Kevin.
Thank you.
If you enjoyed this episode, you might also enjoy getting our 7 Insights newsletter. This is a once per month email where I share 7 of the most valuable insights I've uncovered in the previous 30 days. It includes book, podcast, and documentary recommendations, as well as questions and quotes specifically curated to help you live a more creative, intentional, and meaningful life. It currently goes out to over 50,000 subscribers each month. And if you're interested in joining them, you can sign up via the link in the description.